Excellent. Welcome again to part two of our presentation. We're going to talk about splint therapy, and we're going to try and make it very clinically relevant for you, and trying to share our experiences of making splints and our feeling about it. Of course, we'll focus on one particular type that we use mostly in practice, which I think is most in practice. So without further ado, let's go into the presentation. So essentially, there are various types of splints, of course. The one I use mostly in practice is a full coverage occlusal stabilization splint. This is a hard splint. This can, if it can either be on the upper jaw or the lower jaw. And then, of course, there are various types of splints that you're kind of aware of. They can be partial or full coverage, and of course, certain ones that are kind of designed to actually mandibular reposition. Either they're repositioning the mandible in a particular position to recapture the disc in certain cases, or indeed you might have come across the splints for actually the anti-snoring. But primarily the prescription of this sort of splint is very important. In my practice, I find that we use these sort of splints mostly for our practice. And I think, Shamir, that's your experience as well with these?
Yeah, I think, as a sort of a general point, when you're prescribing a splint, I think you really do need to be aware of the pitfalls, especially with sort of partial coverage splints, with uncontrolled tooth movement, etc. When you're looking at sort of mandibular advancement splints, I think you really do need to know what you're doing when you're prescribing those sort of things. But, I think this particular type of full coverage, hard acrylic splint, where you're looking at, providing a specific occlusal platform is very invaluable for all sorts of purposes, be it, for protecting restorations, treatment of, various sort of types of TMJ related pathology, if you like, testing a patient's acceptance of a change to their occlusal scheme, especially with the wear cases that we were talking about, when there might be a change in the OVD that you're planning. I think that these splints, certainly I prescribe them, and I think it's something which is helpful to know how to do it correctly as well.
Yeah, and I think the thing that I'd like to add, and as you partly mentioned, the partial coverage splints, particularly the localized occlusal interference splints, if you have them, a bit like what we showed in our last presentation on tooth, where that particular dial appliance would be a sort of a localized splint. You have to be aware that when you're using partial splints, is of all this tooth movement that can take place elsewhere. And to be a bit mindful that if with partial coverage splits, particularly long term, that can be become an issue with the movement of teeth elsewhere around. And there are certain aspects where I sometimes use a partial splint. Particularly, it's kind of a almost like a Lucia jig type appliance, which you can wear in the anterior of the mouth, is for patients just to get them temporarily comfortable if they're actually the muscles have gone into a particular spasm. But then I always like to switch to a full coverage as soon as possible, rather than leave them with any sort of partial for any length of time. I'm aware that these splints can also be made in a bilaminar way, where the inside is a little bit softer than the outside. I personally have not got much experience with them. I have sort of read that the separation between the two layers can occur, and of course there is an issue about the mobility of these splints if once they're in place. To create a kind of very firm occlusal sort of contacts, and it's important that the splint does not move, and so maybe the bilaminar may have some potential for movement there. Very briefly, I would if I bring in soft splints, which again I use very temporarily. And again, there's for patients, particularly for sort of sport injuries, and I do refrain from using soft splints for patients who are bruxing, or we're looking at prescribing an occlusal prescription for a patient, because it's very difficult to do that with a soft splint. So before we kind of go into describing the occlusal, prescription that we would describe on a hard splint, Shamir, any other thoughts to add on to these partial splints, bilaminar or soft ones?
Yeah, I think with partial splints, I'm very nervous with not where you're looking at a loose COG, and certainly we can also use these to help establish centric relation, which you'll talk about. But I'm very nervous personally with partial splints, because you do really need that patient to kind of attend regularly to make sure that there's nothing untoward going on. And sometimes you can't predict that. If it's a patient that you've known for a very long time, it's different. But if they're not going to come as often as you might hope, I am aware of cases that I've come across, certainly, where patient compliance hasn't been there, and 4 years later they come back, or they've been somewhere else, and you've got a disaster on your hands. I suspect it probably doesn't happen very often, but when it does, it's a very, very challenging situation to have. Going back to the bilaminar splints, I've made a few of those, prescribed a few of those, and my feelings are exactly what you described. What I've found with them is, as you go towards the second, third molar area, where there's a lot more sort of occlusal loading, I found that the hard acrylic sort of outer coating starts to either wear away or chip, or certainly at the very distal aspect of the splint, the two materials start sort of delaminating. And I found that in some patients, the splints really do not last very long before I've got to replace it. And again, because there's that bounce element, you can't really verify that you've got the occlusal scheme correctly, as you'll speak about in a minute. So I've kind of moved away from the bilaminar. You go through that phase as a practitioner, where you sort of see something, give it a go. But personally, for me, it hasn't worked as well as I've heard it has for other people.
Yeah. Now, coming back to the occlusal prescription of these splints that I usually go for, and as you see on this on the video on the left, you saw an upper one, and the right you saw a lower one. The occlusal scheme, the mutually protective occlusal scheme, is the one that I usually prescribe for these kind of splints, where we're looking for even centric contacts. I'm afraid I can't use a pointer on these. I usually use a pointer to actually outline this, but on the top left slide, you'll be able to see that there's a centric stops in equal centric stops all the way around, so that the teeth actually touch the splint equally. It's important to point out that in posteriorly and anteriorly, the surfaces are very flat. In other words, what we don't want is, if there's a cusp, we don't want the cusp to create an indentation into that splint, so that there's any possibility of cusp locking as the patient was to move. So in other words, the surface is flat, and there's equal contact all the way around, and there's an anterior platform which allows for posterior disclusion when the patient is in excursive movements protrusively and laterally. And this is what you saw on the videos underneath, and that's what we would be aiming for the occlusal prescription, whether it be upper or lower, for the splints. The lower ones, they usually work for very good for class 3s. It is a question of clinical preference, whether we go for the upper or lower. I usually end up making the upper ones more, but you can make the lower ones for a class 3 situation. But the occlusal prescription is always the same, regardless of whether it's on the top or bottom. It's even centric stops, and then you have a bite plane which allows for disclusion posteriorly as the patient goes into excursion. What we're going to do in our next slide is that I'm going to take you through the step-by-step ways in which we would make a device like this, and highlight for you certain aspects which I hope you find useful when you come to construct them, and how you do them. We'll go through the clinical as well as some of the laboratory procedures with it, and then the fitting, and then finally we'll look at the monitoring and what you will do. Now, what we've done is kind of going to liaise a little bit with the production team, and I hope this works out, where we're going to go on to the next slide. So if the production team are listening, we're going to go on to the video that I sent you, and which we could move to, please. Thank you. So here we have looking at the hard acrylic occlusal stabilizing splint. And the first thing I would say is that the opposing arch I take in alginate. And so for this, I'm describing the fabrication of an upper full occlusal splint. So the lower impression is in alginate, and I use a metal non-perforated rim-lock tray with no adhesive. And this allows me to get a fairly accurate, and it's very important to trim the impression so that it's completely enclosed within the tray, and of course it has to be right side. But my preference is to actually use a alginate and in a metal rim-lock non-perforated tray without adhesive for the opposing arch. Shamir, would you agree with that approach on that?
Yeah, so I think I have used that approach, and I do use that approach. I think there's a number of things that you've highlighted on. I think the impression has to be accurate. With these, any sort of flaws, and you find yourself, really in a difficult position. So the impression's got to be accurate. Make sure you dry the surfaces before you take it. When I use the alginate, it's important to use a right type of, high accuracy one. I tend to use Hydrogum by Zermac. I find that quite a good product. Again, when you talked about trimming edges, it's very important when you put the impression down like that. If you've got lots of flash excess, it can sort of move the material away. So important that it's trimmed away. I sometimes also use a special tray. So I have a set of special trays made and use a PVS material in that. But absolutely, I've used this approach, and I find that it works very well in the cases that I've done.
If you could advance the video again for us, please. The opposing arch I take in a similar tray. It's a metal rim lock tray that I use, and I always use a medium body to heavy body with a light body wash to capture the occlusal surfaces and the fine detail. This has been my always protocol. So the arch on which I'm going to make the splint, I always do in a silicone. And again, it's a metal rim lock tray with either heavy or medium body along with light body, and no adhesive as well here. And the material has to be well trimmed from the sides, and that's usually my preference for the opposing arch. I resist using a putty consistency for my silicones. I don't know how you feel about that, Shamir, but I tend not to use putty so much.
Yeah, absolutely. Yeah, agree with that. As I said, if I was going to use where I use a silicone, I tend to usually get a special tray made, as you might do for crown and bridge work. There might be some circumstances where patient-based, where I find the special tray to be right in that case. But certainly this approach is fine. I'm sure there are people who, within the audience who probably use CAD/CAM to take impressions. I don't have experience with that myself, but I've seen quite a lot of that done, certainly by our MSc students, and I've seen very nice results with that as well. So really, it's a case of how you ascertain, that accurate, good quality impression.
Absolutely. And I think the important thing to add, if you are using a special tray, is that you can actually incorporate some occlusal stops, which allows you to have adequate thickness of material in there to capture the details that you want. If we could just proceed the video again, please. So I do a faceable record for the splints, and again, Shamir touched upon that we are actually covering, so if you like, the analog way of making a splint. I think a lot of us are making them still analog. Digital, it can be done, and of course the same principles would apply digitally. The accuracy of the impressions, and of course orientating the maxillary occlusal plane to the intercondylar axis is from method. So if you use a digital faceable and or an analog one, here we're using an analog one. This is the DINA system, and this is a particular type of wax. This is not soft wax. This is Mocha Beauty wax. This basically, once it's cool, is very firm. It will actually break if it doesn't, if it's kind of bent at that stage. So, and what you're looking for is creating very indentations of the occlusal surface. You do not want too much detail. And if you could just proceed to the next, proceed with the video to the next bit, what you will see is that we're basically trying to capture the cusp tips rather than, and just stop the video for a moment. Yeah, we capture the cusp tips that you saw in the, just previously. You saw I was using temp bond to refine the areas. You can use silicone for this. However, just be mindful that if you capture too much detail of the fissure patterns, then it's going to be difficult to seep that cast onto that record. So I tend to use either this method or maybe use the silicone sparingly. Here it's quite useful if you do have your cast pre-made, then you're able to actually confirm the seating of that cast onto this Facebook record. And sometimes I have these casts, they're poured and they're sent to me. So when I'm doing these records, I can keep checking that the accuracy is there. So that is also possible. But this is my preference in order to get a minimal sort of indentation of the cusp, so that I'm able to locate the upper cast or the cast that I'm going to make the splint on quite accurately onto the record. I think you use a similar sort of system, do you? No.
Yeah. So I tend to use that. I used to use green stick a fair bit. I think as a tip, having that maxillary cast available is brilliant. You really want to make sure that it does seat properly and doesn't rock around. If it does, it tells you that there's something wrong. I think with silicone, another tip to ensure my sort of early experiences where I do the silicone, take it off, whatever impressions disinfected, patients walked out, and the silicone's fallen off. And it's important to make sure that you put some silicone on the underside of the bite fork as well, so that it stays in place. And these are sort of lessons that you learn the hard way, especially when the patients come from halfway up the country.
If you want to proceed with the video again for us. So that's the face ball being taken and using that and kind of to just show that you're just really looking for the indentations. And then this can, of course, depending on which face ball system you're using, you will just send it to the technician. In this particular system, this is the DINA system, the Whitmix, and you just basically undo the jig, and that goes on to the technician on there. The next record really we take is the retruder arc of closure record. There are various methods of doing this. I particularly find the leaf gauge quite useful. One of the things I would mention to this is that if you're taking the retruder arc of closure record, is that I try to capture it, and you'll probably see it in the next view as well. I try to capture it at the thickness that I would like the splint at. So in other words, I want to really limit the amount of opening that takes place on the articular level. So basically what actually happens, I'm taking this leaf gauge record, and the teeth are separate, and I'm trying to capture it at that separation, so that when it goes to the laboratory, the technician does not have to open the articulator by much or hardly any, or I prefer them not to open it, because as soon as the technician rather opens the articulator, there are much more chances of errors creeping in. So I'm trying to capture the separation as best as possible using that, and I find I want to really limit what the technician will have to open in the laboratory.
Yeah, I think it's a really nice technique. As an alternative, I used to use Lucia jigs before, which I'd make it up before the patient arrives. But you do end up doing a lot of adjustments, with those, especially when you might be doing a Gothic arch tracing to help establish where centric relation is. But also, as you said, you want to keep the intraocclusal record to as reasonably thin as possible. And sometimes with the Lucia jig, you spend quite a bit of time just grinding away the acrylic to, reduce that space as best as possible.
And what you're seeing here is to help the technician locate this. Basically, because it's an open tooth position that we're trying to capture, I've placed 2 bits of composites on either side, and these actually kind of act as sort of a support for the teeth. So what basically happens then is that they are set. Of course, make sure that you Vaseline the teeth before you put this composite. You don't want to stick this composite onto any existing composite that would be on the teeth, and then you kind of set these. And if you run the video forward now, and as you set these, so these can be used, and so when the patient can open, you can actually guide them into it. So here's the separation that I'm looking for, and you can move the video forward again, please. And then you basically use the material in between in order to record it. So those composite stops, if you like, just have an extra bit of security for this, and you can actually use a silicone bite registration materials, or if you prefer, you can actually get the patient to open, take away the leaf gauge, but leave the composites in place, and then use your recording medium posteriorly. And then what the composite positioners do is allows the mandible to then close back to that position, so you can actually capture it in that open position. Okay, and if you move the video forward again for me, please. And that's what's happening here. I'm just using a bite registration material onto that, and that's the kind of the retruder arc of closure record. Now here is I'm recording the right lateral record, and I'll also be recording the left lateral record. Now I have to say for this, there's 2 points I would like to make. One is that I tend to take this as an open tooth position. So in other words, I do not get the patient to grind to the left and grind to the right to capture a tooth contact position, because that to me gives a tooth reference, not a condylar reference, is what I'm after. So essentially the mouth stays slightly open and goes to the left or the right. And then and I use these composite stops again to support the mandible in that particular position. And then I will use the bite registration material to do this. So by recording the right and left lateral, that gives me the both the protrusive record as well as the translation of the condylar head as well. And the other thing I would like to add to this is that if I am not doing my left and right lateral records, then I would use average values on the articulator for this. So essentially, I will use the average values at the back if I am not recording left or right laterals. But if I want to use them, this particular patient has a sort of redundancy of TND, so I want to actually record it, and that's I'm recording the left and right laterals. And I guess, Shamir, I don't know if you would agree that, generally speaking, if you're not doing these records, then you can actually use the average values on the articulator.
Yeah, so for the purpose of constructing this appliance, yeah, I tend to do that, yeah.
So if you just roll the video forward now. So now kind of getting the right lateral record with the patient's mandible going towards the right. Again, the set composite is allowing me to help support the mandible in that position, because again, it's an open tooth position. And in a similar way, you can actually do the left lateral record as well. Now, as far as the technician is concerned, that he'll get the models, and then they will start using your Facebook record will mount the upper cast. And what I wanted to show here is that you can actually see some sort of metal reinforcements running from the cast onto the wax, onto the face bow. And this really allows for the accuracy while the plaster is setting onto that. So making sure that that cast does not lift off from that Facebook record. And I think, Shamir, you also insist on this location so that the upper cast is very accurately positioned onto the Facebook registration.
Yeah, and as I said in the beginning, very sort of small problems, inaccuracies that sort of creep throughout the process, they can sometimes add up, and it just saves a lot of headache with all the adjustments afterwards. So, anything that you can try and do to improve the accuracy of the process within reason is very good.
A thing to add here also, sometimes I do, is if I've had the upper and lower impressions cast and they're actually have been poured, and I have them trimmed and ready with me at the chair side, then I can also check for the accuracy. And the other thing that I sometimes do is that in my first appointment, we have the upper cast mounted up so that the upper cast is done like that. And sometimes I mount the lower cast with me at the chair side, but not always. But usually I find with a sort of a very secure intra-occlusal record, the technician is able to actually locate the lower cast for you. But if we move the video along now, please. So here now we have the retruded arc of closure, and that's been mounted on there. And the left and right laterals correspond to the, so if you were the left protrusive lateral record, you would get the right readings for the articulator, and vice versa for the other ones. But like I mentioned, if you're not actually doing the lateral records, then you would use the average values at this stage. This you can only program the articulator if you've taken the lateral records. And here, if you see that because I have taken lateral records, you will see that the condylar guidance angle on either side is slightly different. And this is only because I have taken those lateral records. Now, so essentially, just to repeat that if you have the left lateral record, you can do the condylar settings on the right-hand side and vice versa, okay? But if you're not taking lateral records, then you can actually use average values here at this level. The reason why you see a difference between the two is because I have used specific lateral records. I would have to say in the majority of cases, I tend not to use a lateral record. I go for the average values. And I think, Shamir, I'll share your experiences here as well. How often do you take lateral records for your splints?
Yeah, no, not very often. I tend to use the average values as well. Not very often. I have done on the odd case. I think the other thing with the lateral records sometimes is the consistency. As you said, it's an open. It's not a tooth contact position that you're recording. It's an open mouth. Ensuring that the mandible is correctly positioned, etc. We know that there are all sorts of errors that can creep in, and I think for this, obviously if it was a different type of treatment, it's different. But for this, I'm quite comfortable using average values.
Yeah, and I think that what you could do, and as well as these average values, of course, you could take a protrusive record if you like this to help you. But essentially, if you're not taking these records, then you can actually use average values at these settings, okay? And if you'd like to move the video along, please. So essentially now what happens is that the reason why the impression was taken in a silicone material for the arch that you want to make the splint on is so that it can be duplicated. And so you can see that using the wax, the undercuts have been sort of blocked out. And so there is a working model that's been made with a blocked out cast. And so if you just move the video along now, please. And on that one, my technician is waxing up the splint. And what we're looking for is the occlusal prescription that I mentioned to you earlier. Even centric contacts as the patient comes together in centric. And then, of course, when they're moving left and right, there's an anterior guidance platform which allows for the disclusion of the posterior teeth. I think, Shamir, you mentioned that it has been described sometimes that you can get this wax up back to try and check in the mouth. I tend not to do that. I don't know if you do that at all.
I haven't done it, and I think I'd be a little bit worried doing it in that I could very well imagine that it distorts quite substantially. But I have read about that stage, which just helps to verify that the sculpting of the occlusal platform is more or less correct. So I have read about sort of wax tryings, not something I've done myself though.
You can carry on with the video, please. So essentially, the technician is waxing that up, looking and conforming to that prescription. And of course, like I mentioned to you, that if you're able to capture the vertical position, so that the technician does not have to open the articulator much. Then that allows for less chance of inaccuracies creeping in onto that. So essentially what the technician is doing here is looking for a flat occlusal plane to have even centric contacts and a anterior guidance platform in order to create posterior disclusion as the patient is moving in the excursive positions are in the mandible, protrusively left and right. You're looking for equal distribution of forces there. Now here's the flasking. Here's where the blocking of that was quite important. You flask and pack the acrylic, and then it is kind of confirmed. So here you see, because you've got a second, because often you can break a cast in order to get this off. This is where the original cast comes into play, where the splint is refitted. So you're confirming that the splint still fits. So this is why you have those two models, and you might make the final adjustments, and the splint is then polished and sent. So what I'm looking for here now is when I've got the splint back in the surgery, I'm looking for even contacts. I will basically take a shim stock now and actually check that the contacts are even all the way around on this. And I check this outside the mouth initially to make sure that we've got even centric contacts all the way around. And looking for a smooth surface, and placing the splint in here. What I would say is that just hold the video there for a moment, please. Just hold the video if you could. Just stop the video for me. Okay, fair enough. Basically, what I was going to say is that sometimes what I'm checking here is, of course, what I show the sim stock holds before, and we're also looking at when the patient goes from forward and back. They're looking for posterior disclusion. One thing I was going to mention here is that when you're actually first fitting the splint, of course, if this is done quite accurately across the splint should be quite stable on when you place it. But if you find that when you place the splint inside the mouth, there's a slight rock. In other words, it's kind of separating from one side. You can reline the splint, but the tip would be that if you need to reline the splint in that area, is that you can abrade that area where essentially you put the splint in and there's a little gap on one side that you're seeing and where it onto which rocks. What you can do is on the fitting surface, you can actually air abrade that area of the splint and use something like ortho resin in that area. But when you replace the splint back into the mouth, make sure you don't pressure the area where you've relined. Your pressure should be on the other side, and so that in that reline area, it's passive and it's setting there, and that would prevent certain rocks. I tend not to use a clasp, but I think, Shamir, sometimes you do recommend the use of clasps or to aid retention.
Yeah, I mean, if you kind of anticipate that retention is going to be a problem because of the lack of appropriate undercuts, etc., you can prescribe. I've seen Adams clasps being used on the sixes. Equally, you could prescribe some ball-ended clasps. I had done that before. When the splint has come back, it's fine. It's just a bit slack, and you send it back, and you can have those, or you can have them built into the design in the first place. The splint does need to be quite tight fitting, of course.
Regarding the adjustment, then I will cover the review of the splint after this. But essentially, sometimes, of course, you appreciate that if the patient is wearing the splint consistently, and you do any restorative procedure on a particular tooth, then rather than have to remake the whole splint, what I tend to do is actually I always send the splint along with my other impressions to the technician so they can make any sort of minor adjustments. But similarly to the reline process, that if you are changing the contour of a particular tooth, then what you can do is do the same relining process. You just relieve the splint in that area, and essentially make a space. You air abrade and you roughen the surface of the fitting surface of the splint, and then you can actually use a reline material. Sometimes I've used composite, but the main thing is to actually not press on the area that you're relining, you press on the other side in order to it to be there. When you're looking at the occlusal contacts, of course, you're looking at the shim stock holes like you saw earlier on. You're looking at a flat surface contact, even contact all the way around. And when the patient is moving in lateral excursions, you're looking for posterior disclusion. So if you could just run the video through now for me, please. So this is what I'm checking, is that the shim stock is holes, and then when the patient moves forward and back, there's sort of disclusion. You can actually continue with the video, actually, that's fine. We can finish it through. If you're going to use articulating paper, I use the GHM variety. Was that what you use as well, Shamir?
Yeah. So use different colors. So use one color to mark the centric stops, and use another color to check that I've got shared contacts and protrusion. And then I'd probably use another color to check that the canine guidance is there as well. Or at least use one for the centric stops and one for the assessing the dynamic movements. Yes, I would use the GHM.
I think we were discussing this before as well, Shamir, is that when we're looking at these occlusal contacts, the time that you actually give the splint to the patient, sometimes it's not the best time to actually do any minor adjustments. It's probably best to do this getting the patient back after they've actually worn the splint for a little while, so then actually gets them accustomed to this, sort of, if you like, the new jaw position a little bit, because there is kind of a new device. And so rather than do any sort of fine tuning at the time of the issuing of the splint, getting the patient back in about a couple of weeks in order to then fine tune the contact points would be quite useful. And here you also see on this slide that there's a flat occlusal surface where the opposing cusps are not locking.
Yeah, I mean, if I was to share a tip, it would be that sometimes you get it back. Obviously, that you've taken your records in centric relation. The patient is in the intercuspal position, or might be in a sort of a different location. You put it in, and the whole thing looks badly off. And there is that temptation to start drilling away and adding to it, etc. I think one of the things I've learned is, obviously there's some gross adjustments that need to be made. That's fine, but to give it to the patient. And often when they come back, when there's been a bit of sort of distalization, when you then mark up the context, they look pretty much a lot closer to what you were hoping for than what you might have seen when you fit it in the beginning.
Yes. If I could just ask the production team to go back to our presentation now, please. That's great. And I'll just, so what's happening here is the patient has come back, and I'm just reviewing the splint. I essentially recommend that the patient wears for the first 2 or 3 weeks. I ask them to wear the splint every night, and if they can during the day, to actually keep the in as much as possible. And then I review the patient in 2 weeks' time to make any minor adjustments, and if that's required. And then after that, I ask them to sort of bring the splint in for every checkup appointment or the examination appointments thereafter. So essentially, that's what we're looking for. And then, of course, we keep checking without the splint in place of the contacts on the teeth as well. In this particular patient, I'm just making sure that the occlusal contacts on the teeth are maintained, and I check the splint prescription every time. And so what you can see here is that if the patient does wear the splint quite regularly, you'll start to see some sort of wear marks on the splint, and of course you'll also see some indentations at the back, which you might have when the patient has worn it for a particular length of time. But it's important that when you see these wear marks, so if I can just go on to this next slide. When you see these wear marks, and this is a patient that I'm again reviewing it, is to actually make sure that you're able to smooth these out and make sure that the patient is able to, the cusp don't lock. So in a moment, you'll see that I'm checking for the excursions here, but then when you have a look at the splint that has been worn for a period of time, you will see that there are sort of indentations that have been made. and you can mark them up with some articulating paper. And then the idea is to basically trim that on the sides so that the indentation is flattened out. So you maintain the centric stop, but then you kind of actually you make sure that it's flattened out on the outside so that you prevent this cusp from locking. And this can happen if the patient is wearing the splint for a long length of time. Regards the frequency of wear, there is some evidence that if the splint is worn and then not worn for a period of time, that kind of helps control the bruxism. It's almost like sort of training and retraining the muscles a little bit. I asked the patient to wear quite regularly initially before I asked them to sort of give certain breaks to it. The compliance of wearing a splint is low. Usually I find it higher in patients who are getting some relief of any symptoms that they might have. They seem to comply more than others. And of course, they also comply very initially while following restorative treatment. And that's the sort of, if you like, the overall, summary of how we would go about making any the splints. So just to kind of recap, so we kind of with these is that this is a sort of splint that we use mostly in practice, a full coverage hard occlusal wear. Generally speaking, I'm making an upper splint rather than the lower one. The prescription is how we've described it, and the constructions that you see. And if you want, hopefully shared some sort of tips to actually minimizing the errors and how you would adjust and maintain these splints long term. So I'm going to pass you over to Shamir now. If there was anything else you wanted to add to that, Shamir, onto these splints.
No, nothing further to add. Thanks. I guess we could take some questions at this stage.
That's wonderful, chaps. Thank you very much. Amazing. And I hope you all enjoyed it. Those of you in the audience, I certainly did. If this has whetted your appetite, you can read a lot more about it in the Toothwear book written by these gentlemen. Time for just a few questions. One from Michelle. What if the tooth loss, tooth wear, is not a cause of concern for the patient? Should we still refer the patient?
Well, from my point of view, I would say that if the patient is not concerned and if the clinician is not concerned, then of course we would just institute preventative management and monitor it. That would be my view. However, if I was concerned as a clinician, then I would like to actually discuss with the patient the consequences of what would happen if the tooth loss continued. Shamir, I don't know if you want to add anything to that.
No, I agree with that fully.
I think if the patient isn't worried, the chances of them complying with treatment are not very high. Just a comment from Siva, where might also depend on activities like betel chewing. Two questions, interestingly. What do you advise about severe tooth wear in deciduous teeth?
Very difficult. I think there's I would have to say, luckily, I don't see a lot of pediatric patients, but I think it's just a management issue. It's a very difficult one to manage. I think making the parent aware of it, and of course, if it's deciduous teeth, we're kind of preparing a little bit for the permanent dentition. But I don't prescribe any treatment as such. I don't know, Shamir, if you're aware of any treatment on deciduous wearing dentition.
No, I haven't prescribed as such, but we do see a lot of it now, and we know that sort of, if we look at global prevalence rates, they're estimated to be in that sort of 30% region for the deciduous dentition. So it is a problem. Usually, it's a case of taking that history and establishing what's caused it. And as we're seeing, sort of healthy substitutions. With parents moving away from the fizzy drinks and all that causes damage. But the kids are eating a lot of fruit. Certainly, I know my children used to eat a lot of fruits. My elder son was, he had grapes after every meal, and he had eroded tooth wear. But it's not something that I picked up on, and it's when I checked his teeth. Oh yes, this is what the likely thing is. It's just taking that history, asking the right questions, and giving the right advice, really.
Thanks, Shamir. The comment from Steve, worth mentioning that age and disease-related issues like reduced salivary flow reduced saliva buffering, diminished tongue movement, etc., will also maybe contribute. And probably time for the last question from Orna. What is the wear pattern of natural teeth opposing metal restored dentition, as in dal restoration, especially in the anterior dentition?
I'll let Shamir take that one. This sounds like a very difficult question.
I don't know the answer to that, so I won't lie, but I will base it on my own experience. Right? In cases where I prescribed nickel chromium backings, and these are going back sort of 15 years or so, I have seen signs of wear on the lower teeth which were not there in the beginning. So I think the type of material you use is important. I haven't used nickel chromium for a while. Obviously, composite is going to be that much more gentle than using, sort of stiffer metals, if you like. I don't know how gold. I guess gold is that is a bit more elastic. Is probably going to be less sort of damaging to the antagonistic surfaces.
Excellent. Last one from Ahmed. Do you often get localized pain on the teeth you're adding the composite to because they're the only teeth in occlusion? Well, I can answer that one probably. Yes, that should be included in your patient information leaflet, really, or your patient information and patient consent things. But chaps, that was absolutely fabulous. I love the way of doing it, the interaction between the two of you. Maybe one last one on the second part of your presentation. Is a soft splint not routinely recommended? This is from Michelle. I normally advise a soft splint. Should I not be doing that? But thank you. Many complimentary comments, by the way, about your presentation. Can't thank you enough.
Thank you very much.
Thank you.
Okay, round of applause to everyone. Thank you very much, chaps. Wonderful.